with that all being said, let's go ahead and get started. We hope this is going to be a high yield review. And it's cool to see people at different stages of their medical training because all of us, all of y'all, especially y'all in EM, IM, even PM&R, I don't know how much chest X-ray you guys are gonna do, but you're gonna need to look at a chest ray at some point in your training. So this is great. Okay, we'll get started. Oh yeah, so our agenda today, we're going to go over some common indications to get an X-ray, chest X-ray. We'll go over what a normal chest X-ray looks like, as well as an approach to reading one. From there, we'll go through some annotated examples together where I'd love everybody's participation to call out and point out things that look abnormal to folks, which are our walkthrough cases, and then we'll wrap up with some pearls at the end. So I'll hand it off to Jacob.
Awesome. So this is meant to be a very just kind of high yield talk. Hopefully some things stick in your brain. If you get that random pimp question on your IM wards or another rotation, ICU maybe in your fourth year, hopefully these things come back to you. So we'll start with indications, something your attending or senior resident can say, why did we get this chest x-ray? What are some reasons why you'd want to get a chest x-ray if a patient's coming into the ED or to the hospital? So these are some of just the common causes that you could see. Of course, X-ray looks a lot at the lung field. So one of the biggest things that you could be evaluating for is shortness of breath, which has different causes in itself, or dyspnea. It could evaluate for heart failure with fluid overload causing that shortness of breath, or something like a pneumothorax, a collapsed lung, also causing shortness of breath. If someone's coming in with productive cough or fever, you want to look for lobar pneumonia or some sort of infiltrative pneumonia, possibly other consolidation. If someone comes in with chest pain, one of the first things that can be done is a chest x-ray to look out for a life-threatening aortic dissection seen on widened mediastinum that we'll look at later. Also, trauma. If someone's come in after a motor vehicle accident, some other acute blunt traumatic force to any of the chest, abdominal areas, you could look for rib fractures. Again, you'll see this word pneumothorax a bunch of times till you're sick of it. We should abbreviate it to PTX because that's what you'll see it a lot as well. And then finally, sometimes screening. If someone has already like primary malignancies somewhere else, they could possibly get a chest x-ray to screen for other nodules or masses or other things that could indicate cancer. Yes, and please look in the chat for Kuya Manny's like high yield tips as he annotates and provides his expertise as a clinician educator, academic hospitalist. So one other common indication is looking at line tube placement, looking at central lines, ET tubes, NG tubes. So there's multiple approaches to reading a chest x-ray. I'm just going to introduce one that, I was taught in my medical school. And when I'm asked on the wards, sometimes, a senior, there's a lot going on and they'll say, how are you approaching this, right? Instead of just calling things out, they actually want to hear what is your systematic way to approach it? Because it's super helpful when you have a similar way to do something every time. So one schema is just looking through the A, B, C, D, E. It goes beyond E, but we're just going to keep it simple with this for now. Insert A stands for airway, and you're mainly looking at the trachea. You can see it outlined in this image here. It'll be this anechoic or black space in between the midline processes. If you have a good x-ray where the patient isn't tilted one way or the other, it should be right in between the clavicles, which you can see pointed out, as well as right in between the spinal processes. You got some good focus. It should be a dark column in the center, and some abnormalities you're looking for if it's pushed to one side or the other, that's called tracheal deviation, and it could suggest a medical emergency like a tension pneumothorax, which we'll get into with more detail, or complications maybe from an aortic dissection as you look lower down the tracheal area, close to that red area called the aortic knuckle. So we'll retouch on these terms as we go through the cases, but when you're looking at A, you're looking at where is the airway. For B, I like to say that it stands for breathing, which includes the lungs and the pleura and bones. Some people put bones a little bit later on, but B has that nice, fitting for both of them. So when you're looking at the lungs and the pleura, you're kind of first just scanning. I usually start right in the middle, where they call it perihilar to see if there's any focuses, increased vasculature, and then slowly make your way up and around to the periphery, really just following those arrows. You want to see those line markings go all the way to the edges. Any black space without any like fine vascular markings could be a small pneumothorax or some area that's not getting good airflow. So, as you can see in the description, it should be generally dark, which means filled with air, with fine white lines, which indicate a lot of the pulmonary vasculature. On the image on the right-hand side, you're also looking at the bones at the same time. We said the trachea should be in between the two clavicles. You can see the spinous processes going down the middle. You can see anterior ribs and posterior ribs. Other times you can also look for how wide the rib spaces are. This can tell you if someone has like a chronic COPD picture. And then you're also scanning to see how far the lung field goes down. And we'll talk about the diaphragm a little bit later. A couple abnormal things to point out. If you see it's too white, looking for like fluffy white clouds, alveolar opacities, this could suggest fluid or pus seen in pneumonia or edema. If it's too black, we've indicated a lot. That means that there's less interstitial markings, maybe indicating a pneumothorax. Next in the schema is C, which stands for cardiac. You're looking at the heart size and borders. So if you remember from your anatomy, or when you get to, anatomy or just picturing it, you can see the borders of the heart. The right atrium, right, going towards the left side of your screen, you can see that nice border there. Above that, you can see the right hilum and the pulmonary artery area. If we cross the midline and go to the left, you can see the aortic knuckle, which we've already talked about, the left hilum, pulmonary artery. And then as we go down, you can't see it as clearly, but that's where the descending aorta would go, and the left ventricle would be on that side. Not indicated on this photo, the right ventricle is the most anterior aspect, so closest to the chest wall. So not something that you can see, but good to know where that is when you're thinking of different pathologies. Another thing you're trying to assess with cardiac is measuring how wide the heart is relative to the total chest. And it should be less than 50%. So in this patient, you can see it's close, maybe 50-50, but you can see in future images what a large or cardiomegaly heart looks like. And this is one of the first signs of possible heart failure. A classic chest x-ray won't say heart failure, right? Of course, because they're just looking at the radiology. But when you connect it together clinically, you can say that maybe the cardiomegaly is from the heart failure. All right. Next is I'm kind of grouping together D, which stands for diaphragm, and looking at angles and looking at everything else. So one thing with the diaphragm, this also tells us if there's a chronic possible emphysema or COPD picture, the diaphragm should be humped, right? There should be two humps. Sometimes when it's flatter and pulled more down, that's maybe a chronic COPD picture, or someone that's a long-time smoker. Again, these are things you're going to correlate clinically, but can be the first signs that you can think about and can maybe explain some of their symptoms. On the edges of the diaphragm, you want to look at these areas called the costophrenic angles. They should be sharp like this. Sometimes when you can't see that end point there, that could mean there's fluid there. The fluid could be caused by a lot of things. It could be, just edema fluid. It could be empyema, like pus. It could even be blood. So you want to make sure those angles are nice and sharp and clear on both sides. If they are blunt or meniscus shaped, it suggests maybe blood fluid has pooled there. And then everything else, Kuyamani mentioned like lines, tubes. The example we put here is a pacemaker. So you can see the pacemaker on the left side of the heart. You can see the wiring going into the different leads. We'll skip that for a later talk, but this one has two leads going into two different areas of the heart. And then again, we looked at like the great vessels, clavicle, so anything else that jumps out at you. And then finally, you should always check the mediastinum, which is the center of the chest. If it looks unusually wide, that could be one of the first signs of aortic dissection, which we'll get into. Before I move on to the next abnormal stuff, we just want to pause for any questions or any other teaching points anyone wants to add. All right. So the next time you're quizzed on your rotation, how you're approaching this, start with A, B, C, D, E and try and fill it in.
All right. Thank you, Jacob, for starting us off with that really wonderful approach. I've put that approach in the chat for everybody's reference as we continue on. Now we want to take a second to go through some cases together about what things are abnormal. And I'd love for this to be interactive. So what I'm actually going to have everybody do is if you see in the bottom left-hand corner of your screen, there's a little green pencil icon, and there's a check mark, which is the stamp button. And I'd love for people to maybe using that schema, either put check marks on things that look normal to you, put X marks on things that look kind of weird or abnormal to you, and then maybe a question mark if you're not sure what that looks like or what's going on there. So I'll give everybody about 30 seconds to use the stamp, and I'd love to see, these are what the stamps look like, by the way. That's like a check mark. Here's an X mark. Here's a little question mark. So y'all can go ahead and take a second before we come together and maybe talk about some of the things we're seeing on this chest x-ray. Okay, seeing some X's. Give another 10, 15 seconds for anything people want to point out. Okay. Amazing. We've got some great stuff. So we're going to stay on this slide. And before we move to the next slide, we've got about 4 or 5-ish cases. So honestly, if, it's great practice, especially for those who are in the wards, to just practice reading a chest x-ray out loud. Oftentimes your senior resident or attending will just say like, "What do you see?" And I feel like going through a systematic approach can be really helpful to, demonstrating your knowledge and also just practice yourself. So is anyone brave? Wanting to go through the ABCDE approach, maybe using these X's as their guide. Maybe we'll start with airway. Any comments on airway? Or we can use the reaction. We got thumbs ups on airways, or let's do the O if we have an issue with the airway. Okay, I'm seeing a check mark. Alphonse, you have you unmuted for a second.
Yeah, I mean, Dr. De La Rosa, you could also tap in, but I think the trachea looks midline, so it's okay.
Yeah, that's great. Do you want to try and give some of the other letters a shot?
So B, we have breathing, so we see diffuse opacities bilaterally. Um, so that could be indicative of uh, fibrosis
It's
or
okay.
something.
You can just call out what you see and we'll get to what it could mean afterwards.
Wait, you want me to do like the rest of the letters?
If you'd like to, or if anyone else wants to jump into, but
No, I
maybe
think
she's have you.
yeah, someone else could probably jump in.
Okay, for C, it looks like there's some pretty bad cardiomegaly here, just because, especially on the left side, it's taking up more of, oh, y'all can't see my mouse, but where the X is, it's like extending more than 50%. D, you can't really see the costophrenic angles on both sides, especially on the left side, but you could see on the right that it is definitely blunted. And then E, I don't specifically see any hardware, but of course, correct me if I'm wrong, but I don't see any like a swan or pacemaker leads or anything like that, or ET and G2.
Fantastic job. Isa, go ahead to the next slide. Thank you all so much for participating in that. So yes, all of the spots that there were X's, you guys correctly called out areas that look a little bit different from a normal chest X-ray. So in the hilar regions indicated by the circles number 1, we can see that there is some upper zone vessel enlargement. So those areas look a little bit more opaque and a little bit wider than typical. And then where the circles are for 2 on the left-hand side or the right side of the chest X-ray, we see curly B lines, which I'll have a zoomed in picture of that earlier because the quality on this is not very good. But that is a very classic sign of interstitial edema. Or remind me, do you go by Raffi or is that what you said?
Yeah, Rafi's fun.
Raffi, yeah. Called out that there are these bilateral airspace opacities, which could potentially be alveolar edema. And then, as Diane said, especially on the left lung, the costophrenic angle is blunted. Additionally, there's cardiomegaly, that heart silhouette is more than 50% of the entire chest wall width. So all of these are clinical signs, or sorry, chest X-ray signs that are classic for heart failure. Okay, next slide. And just going in a little bit closer, so those curly B lanes, I've always been like, oh, we read about it all the time. What does that actually mean? So you can see these horizontal lines. They're typically visible kind of on the lateral sides of a chest X-ray, and those can indicate interstitial edema. Any questions before we move on to the next case? Alrighty, let's keep going. So number 2, let's same thing. Go get out your stamps and feel free to start putting X's where things look different. All right. Feel free to put more stamps as we go. But let's get started, sort of same thing. I see an X up near the neck area of the chest X-ray. Would someone like to maybe call out what they're seeing there?
So, it looks like a tracheal deviation to the right.
Yeah, I could see that as well. There's definitely a slight off midline deviation. Great. I see an X kind of on the upper left area of the chest X-ray. Can someone call that one out?
It looks like left atrial enlargement of some sort.
Yeah, there's definitely something weird going on with that border. Um, does anyone have any other ideas of what anatomically that could be? It is in the area of the atrium, I agree.
Is
But
that a
there,
widened mediastinum?
yeah,
Or
it
no?
is a widened mediastinum, and sort of what we'd call out is if you see on the right side the normal chest X-ray, there's that pink outline of the aortic arch, and sometimes that can be called the aortic knuckle. But that looks very different in the one on the left-hand side. It's quite wide. The entire sort of middle area is widened, and you lose that sort of knuckle shape. Okay, I also see an X down near the left diaphragm. What is someone seeing down there?
So it's you can barely see the
Yeah,
diaphragm. And
fantastic.
if anything, the whole image is pretty white. So I'm not sure what that's more indicative of, like a pleural effusion or edema. But yeah.
What a wonderful thought. I agree. I see a lot of white in this picture generally. Sometimes when you see a lot of white on an X-ray, you might also ask yourself about just the quality of the overall image and whether the exposure is quite high. But I agree, the angle of the costophrenic angle is a little bit, it's unclear, it's difficult to see. Makes you wonder if there's some sort of fluid in the area. I also see an X on the right side of the chest X-ray. Can someone call out what's going on over there?
It's like a telemetry lead that's on the patient.
Yes, fantastic. I'm so glad that someone put we did the full A, B, C, D, E approach. We have an E for everything. And yes, so it's important to note that sometimes there are things on the chest X-ray that you're like that you need to make sure you understand what's happening so that you're not like, oh my God, is there something in this patient that I'm not aware of? Yeah, so those are EKG leads. Okay, we'll go to the next slide. Oh wait, okay, darn, ha. Uh, go to the next slide. So all of these clinical signs that everyone correctly pointed out are very classic signs of what is an emergency, a medical emergency, which is aortic dissection. Essentially, that means there's a tearing of the walls of the aorta, and that can quickly lead to destabilization of the patient. There can be blood into the lung and can be quickly medically compromised. So, especially for those of you who are interested in emergency medicine, this is something you might see, especially for folks coming in an MVC or, sorry, motor vehicle accident or other sort of blunt chest trauma. So, widened mediastinum, loss of that aortic knob or knuckle. You might also see a deviation of the trachea if there's already some sort of tension or fluid filling one side of the lung, and hemothorax, which I suspect there's an element of that happening sort of on the left side. Okay, next case. We're doing great. Oh, let me clear out this drawing. Alrighty. Check marks, X's, question marks. What is normal? What is abnormal? Go for it. Okay, this is we had a quick response on this one, and I'm seeing a lot of interesting stamps in a particular area. Does anyone want to call out what they see? Not necessarily what they think is going on, but what do they see that's abnormal?
Starting with A, the trachea doesn't seem to be straight.
Great job. Yeah, the trachea looks like it's pushed towards the right. It's sort of diagonally directed. Wonderful. What else do people see?
Very enlarged left lung.
Yeah, that left-sided lung does look a little bit, or the left area does look kind of maybe bigger or larger compared to the right side. What else can people speak to that they're noticing? I see a lot of X's kind of on the left side near the heart. Can someone call out what they're noticing?
If you compare the level of the cosophrenic angle between the two lungs, the one on the left is like much lower.
Yeah, that's a great point. It looks uneven. Mm-hmm. What's happening with all of these X's that y'all put over here?
So like usually you'd see like the vasculature of the lungs, like the interstitium, but it's
Mm-hmm.
like just completely blacked out.
Yes, yes, that's exactly right. I think, sort of what people are getting at is that it's very obvious that the left side doesn't look like the right side. And you're calling out some important differences that maybe the diaphragm looks uneven or maybe it looks a little bit larger. But what's very clear is that what's happening over here is so black compared to the lines that you see over here. And now that we're looking at it, we can also see that there is something happening right here. Does anyone want to call out what they think that is?
Like a collapsed lung.
Exactly. Yeah. So putting this all together, so for completeness sake, to say what we've talked about, airway looks deviated. In terms of bones, all of the bones look intact as far as I can tell. I don't know if I saw any sort of obvious fractures. Um, in terms of breathing and talking about the lung spaces, we see that there's interstitial markings on the right side, but there's a complete absence of interstitial markings on the left. We also see some sort of soft tissue mass there that Diane correctly identified as a collapsed lung. In terms of C, the cardiac silhouette looks appropriate. It's less than 50% of the entire chest width. And then for D, why am I forgetting what D is? Diaphragm, we do see unevenness of the diaphragm that likely has to do with the pressure difference. And then E, everything else, I didn't notice anything, any hardware or anything particular, but I think that lung outline is certainly one that we want to notice. So on to the next slide. This is,
Do you want to have them try to guess
oh
it?
yeah,
I
you're
just wanted
so
to make
right.
sure I didn't reveal it first.
Anyone want to call out what's going on?
Like attention, you will, correct?
Exactly. Next slide. This is a tension pneumothorax. Very classic constellation of signs, the lack of interstitial markings, the collapsed lung, the tracheal deviation towards the right. For those of you who might be interested in acute settings like emergency medicine, this is yet another can't miss emergency. And it's a situation where typically a chest tube might be entered or put in really quickly to release some of that air and allow the lung to expand again. This is one of those like physiology things where air keeps getting into the chest wall and forcing the lung to be small, but it can't escape because of like a flap of skin. So it just keeps compressing the lung further and further. Okay. Yes, and thank you, Manny, for this pearl. The patient's probably going to be unstable. Um, and if you can't hear breath sounds, it's another great clinical sign that would, likely correlate with the x-ray we're seeing. Okay, next slide. Alrighty, let's keep going. We stamp it up. Yeah. Okay. Um, I agree. There's not too much going on, so I'm glad that people are calling out sort of the big obvious differences. Um, Anyone want to call out why they put an X down somewhere? How they would describe this chest X-ray if your senior resident was like, "What's happening? Read this."
For airway, the trachea looks deviated to the right.
Very, very good. And how would what's some of the terminology we might use to describe what's happening on this right side? Um, So what we can call this right side typically is an opacity. It's probably the most general term that you could use to describe some sort of, um, I was going to say opacity again, but any sort of like whiteness that you see that looks like it's in a certain area, you can generally describe as an opacity, and you kind of separate things into what type of opacity it might be a little bit later. But based on the fact that this is covering a large-ish area of the lung field, um, I might say to my senior or my attending, in addition to a tracheal deviation, that I see an upper right lobe opacity along, like maybe superior to the anterior, the horizontal fissure. So let's head on to the next slide. I think this one's pretty clear what's happening. So this is an example of lobar pneumonia. So typically, I say like the terminology for opacity is like a pretty good one that you can use as a medical student on the wards. Um, based on the clinical picture and based on how that opacity looks and the fact that it's pretty white out, you can get a little bit more clinically specific and call it a consolidation. That plus the fact that it goes along this horizontal fissure, we see that this is a lobar consolidation that's most consistent with a lobar pneumonia. This person's probably not oxygenating too well. I can't really explain the tracheal deviation. I suppose that's probably something that just can happen sometimes, or I don't see if there's anything really going on the right-hand side. So that's interesting, but I'm glad that Janessa, you called that out as well. Next slide. So a question that you might get asked in the wards is like, where is this opacity? And so some landmarks that can be helpful for you. We saw in the previous slide the horizontal fissure. If something's happening superior to that, that'll be your right upper lobe. But distinguishing between the right middle and the right lower lobe can be a little bit more challenging. The left obviously just has an upper and lower, so it can be a little more clear. But some landmarks that you can look at for knowing that it's the middle lobe is the fact that, it'll still be along the horizontal fissure, but specifically the right heart border becomes obscured. So if, you're getting pimped a little bit and they're like, is this middle or lower? Look at the right heart border and see if you can see that. Comparatively, in the right lower lobe, you might not see the horizontal fissure, being the border of the consolidation, but you will see the right heart border. And instead, the diaphragm might be something that's obscured. And then I just want to call out really briefly on this chest x-ray, we see that this patient is someone who has breast tissue. So another thing that you should be able to notice on a chest x-ray. Next slide. Sorry, I have to cough break. Hopefully, I don't need a chest x-ray. Okay. Cool. So we're not going to have a ton of time to really get into all of the types of opacities, but I hope what y'all can appreciate here is that these opacities do not look the same. And as we get more and more experience looking at chest x-rays, we can build a differential for what a person might be experiencing based on how the opacity looks. So feel free to screenshot this page, and especially y'all who are going onto the wards. These are very classic examples of what things might look like. We'll start by seeing on this left-hand side, this opacity is kind of what I would describe to be a whiteout. It's just like uniformly gray or whitish all around. Another thing that I'm noticing is that you can see the outlines of the vessels. You see these dark lines, and those are called air bronchograms. It's just signs of where air is coming through. And in someone who has a lot of stuff in their lungs, those become more visible. And then generally, someone might be like, this is a fluffy chest x-ray. All of these signs point to the fact that the where the fluid or the opacity is in the alveolar compartment. And that's exactly where the little where your gas exchange is happening. So this is very classic for someone who might have an infection or someone who has edema of some sort. Conversely, if we look at this second image, you can see that what some people might describe this as a starry sky. There's a lot of dots and speckles. And this is an example of a nodular type pattern. And this can point you to different diagnoses on your differentials, such as TB, fungus, or sarcoid. I don't have an image of, or maybe there are some lines here. This is not the best example, but interstitial compartment can also have lines. And then finally, just down here, you can see that there are some very obvious looking circles, right? And this one doesn't have the best examples, but you can also see some stand-up lines. And what we're looking at here is a disease in the airways. The reason that we're seeing circles and we're seeing lines is because your airways in the lungs are shaped kind of like tubes. And sometimes in a chest x-ray, you're seeing them blocked this way, so you'll see a circle, or you're seeing them blocked this way, in which case you'll see it like a pipe along the sides. So those are sort of the two different things that you might see. And for that pattern, there's a lot of different things that could be causing that, like plugging is an example. But these are sort of this is great terminology that you can use on the wards to describe not just the opacity, but what where it's located and what compartment you think it's in. Okay. Next slide. Okay, so we unfortunately aren't going to be able to cover like every little thing on a chest x-ray, but I do want to call out that sometimes we'll see some nodules. And you might wonder what's going to differentiate a benign nodule from something we might be a little more concerned about. This is another just high yield table that y'all can take home. On the left-hand side over here, we see a nodule that is comparatively small. It has a smooth and well-defined border. And this is also something where you'd want to check chest x-rays over time. So this person, maybe he got his checkup last year and had a chest x-ray. Is that nodule the same size? Now, on the left-hand side, we see that this one here is a little bit on the bigger side. We also see that the borders are a little less defined and might be what you would call a spiculated border. Another concerning feature would be if this person had a chest x-ray like 2 months ago and this didn't exist. So those are signs that you might want to get a CT or get further workup on what might be going on. Clinical history is also important. Has this person smoked a long time? Does this person have other risk factors for cancer? Okay, next slide. Okay. Oh, darn. Isa, can you reshare? I updated one image, so it might not be updated. I threw in a slide while Jacob was still talking because I realized I just wanted to call out hardware real quick. While that's being pulled up, any questions so far? I know I'm moving a little bit fast. We'll make sure these slides get sent out to folks, and you feel free to take screenshots of stuff. Here I just want to call out some examples of hardware. I know the quality is not necessarily the most ideal, but kind of as we talked about here, oh, let me annotate again. So we're seeing some EKG leads. These are all things that you're like, all right, no big deal. But also something that you might see on a patient are these wires right here. Does anybody know what that might be? Has anyone seen that on the wards?
Sternal wires, I
Yeah,
suppose
sternal
open
wires.
heart.
Exactly. So for folks who ever had like an open heart surgery, they had to have a sternotomy where they opened up the chest wall. Those kind of live in a person forever after that. So those have, I feel like in older patients, I kind of see that pretty often. Another thing you might see is pretty subtle. Does anyone have something that they notice in this second image?
Is that a stent?
Yes, sir. That is a stent. She is so subtle, but we love it and probably save this man from a lot of chest pain and perhaps his life. So, stents are important when people come in with a heart attack. It's a blocked vessel in the heart. You send them straight to the cath lab and you get that opened. So, that also is something that remains in a person forever. And then finally, what are we seeing in that third image on the right?
This is a like wild guess, but is it supposed to be like an NG2, but it ended up being in the lungs instead of in the gut? Or no?
Yes, very good. Excellent call out. So this squiggly little thing is an NG tube, a nasogastric tube. It's inserted through the nose. It's supposed to end in the stomach. This is typically for folks who are unable to take things by mouth. And what you're correctly calling out is that it doesn't appear to be in the right place. A typical NG tube would go down sort of along midline along the trachea, and then it would enter the gastric part, which is the stomach. But what we're seeing here is that unfortunately this tube is deviating really quickly. and is probably in the left main bronchus and sort of in the lung. So this is kind of with the example that Manny had put in the chat, we would need to remove and replace the tube into the correct place. Okay, next slide. All right, so those were all of our examples. I hope those were helpful. We're just gonna call out these final pearls just to like consolidate and put everything together. So I'll hand it off to Jacob.
All right, yes, time for the pearls, and hopefully everyone has some Pandesal soon. Trying to break it down kind of by training level, but of course, take what you remember, apply what you need, for your different spaces. For pre-health students, as you're going through these slides, really just focus on the basics. What is white? Usually is fluid and bones. Black is air. And so I try to picture that with your physiology and your anatomy. Try to think of where the different structures are when you're looking at bones, when you're thinking at why black spaces are black spaces, and know that x-rays are measured in density. There's different types of kind of units, as we'll see, for different types of scans. So that's just something that you can think about. For first and second year medical students, as you're starting to think about physiology and pathology, start to think of those slides that you're seeing in class and connect them to what the radiology images are showing. So we've talked a lot about heart failure and different heart failure signs on chest x-ray. So one triad you can look at that we've covered, and just to remember, biggest one is cardiomegaly, right? That's probably the first thing you see right smack dab in the middle. Remember that 50% rule. Curly B lines, which we zoomed in on, you can see those purple arrows pointing to that. Signs of interstitial edema or excess fluid in the lungs. And then finally, blunting of the costophrenic angles. Again, excess fluid dripping down into the spaces that usually would have air and that should be free and sharp. For third year students, right, you're kind of just getting introduced to things, but what we want to really be some big takeaways is some of the can't miss things. So some of the emergencies that we've talked about. The two main ones are aortic dissection, right? The loss of that aortic knob with a widened mediastinum. And some of the clinical signs you'll see is that tearing chest pain, right? You'll get it on your board questions, ripping through to the back. Maybe someone with high blood pressure at first that can maybe drop suddenly to low. Try to connect those things together. This is a red flag, an immediate surgical emergency. And then maybe the last one is that tension pneumothorax. Just some of the classic signs that you'll see. Again, it's a emergency. We've talked about pneumothorax, hemothorax, but we've also mentioned simple and tension. So a simple pneumothorax is a collapsed lung. A tension pneumothorax is when the pressure builds so high, it pushes the heart, other structures to one side, and that's when you get that tracheal deviation. So tracheal deviation plus pneumothorax, right? That's tension, that's pressure building up. That's why it's called tension. For this one, if you see that black lung field with the trachea deviation, again, this is a life-threatening emergency. And as Kuyamani mentioned in the chat, it's immediate indication with hypoxia and hypotension to put in a chest tube or talk about like needle decompression. So those are our four main pearls. I know we went in depth on a lot of things, but hopefully these main pearls stuck. The different clinical pictures and common things stuck as well. And we ended a little bit early, so we'll pause for any extra teaching tips from Kuyamani or anyone else that has to share, or any questions that y'all have.
Amazing, Issa. You can stop sharing the slides. How's everyone feeling? Can I get like sort of I should have gotten like a thumb meter at the beginning, but how are we sort of feeling about the cases that we went through today? Okay, good. I hope none of this was like super intimidating. We're hopeful that like it's just giving you a framework. And oftentimes I feel like the expectation on wards for those of you who are there is really just like have a standard approach to things and call it what you think is normal and call it what you think is abnormal. we're not necessarily at the stage of training where we're expected to be like, this is what I see, and therefore this is what I know. But the starting point is just identifying things and trust your gut. You know what a normal chest x-ray looks like. And even if you're not sure what things mean, you can just say, that looks a little bit weird to me, and use that ABCDE schema so that you know that you're not missing anything. You know that you've scanned everything on the chest x-ray field. Any questions? Yes. Good luck on your IM rotation, your poem final. Okay. Give it a minute. Kuyamani, any other thoughts?
Yeah, so I will echo what's already been said that it's best to take a systematic approach. That way you won't miss anything critical, especially. And one thing that I love about what we did here is that we showed you all some very life-threatening emergencies that can show up on a chest x-ray that require immediate action. And remember, a chest x-ray is one piece of clinical data. So whenever you're presenting your chest x-ray findings on wards, it's best to tell us you see an opacity in this particular location, or I see blunting of the costophrenic angles. So just stating what the findings are, because then you're going to put that together with all of your other clinical information to form your assessment, which then will drive your plan.
Amazing. Thank you so much for your wisdom. And everybody kind of like take a second to scroll through the chat and save all those links that have been put in there. We'll try and send out a recording. So if you didn't get to take screenshots of some of the tables that you wanted to, we'll get that out to y'all. But thank you all so much for participating, for stamping our screen, and for showing up to today's Pandesal Pearls. We have a lot of exciting programming coming up. In addition to like future Pandesal Pearls, we have some evening reports coming up in January that Issa's going to be leading, which we're so excited about. And we also have a research newsletter that is in development. Jacob and I are in the final stages of putting that together. So keep an eye out for our first CFAM research newsletter highlighting some evidence-based guidelines and things that are hopefully relevant to the Filipino patient community as well. So with that being said, thank you all for spending your evening with us. We look forward to seeing you at the next one, and good luck for everybody who's got upcoming rotations, assessments, and reach out anytime if you have questions or are interested in getting involved in research and education here.